We will continue to do the epidemiological exercises from this lecture onwards. The topic for today is screening for diseases. Screening for diseases, although it is a small topic in your textbook, it is a very high yield topic. There are a lot of MCQs, theory and practical questions that are asked from this topic. So I suggest that you prepare this topic thoroughly. When I'll be taking this lecture, after the theoretical part, we will be solving some examples. I suggest that you take a pen and pencil and solve these examples along with me so that you will understand them better. So whenever we are solving the examples, you can pause the video on the question and try to solve the example yourself. Also, I'll be giving some homework questions which you have to solve and give it to me on WhatsApp. In today's lecture, we will be covering what is screening, what are its aims, how screening tests and diagnostic tests differ, what are the uses of screening, and finally, what are the ways in which we can evaluate a screening test and solve some examples of the evaluation of screening test. First thing that you must understand is the iceberg phenomena of disease. The pattern of disease in hospitals which we see is quite different from what is actually present in the community. In the community, a large proportion of disease remains hidden. To describe this, analogy of an iceberg is used. The clinically apparent cases which are represented by the tip of the iceberg, that is the visible portion of the iceberg, whereas the majority of the portion of iceberg is submerged underwater. This represents the subclinical cases, carriers, asymptomatic cases and undiagnosed cases which form the major burden of disease. These are normally hidden, and it is our job to use proper screening tests to uncover this hidden burden of disease. So, we define screening as the search for unrecognized disease or defect by means of rapidly applied tests, examinations or other procedures in apparently healthy individuals. The search for unrecognized disease or defect. How do we search this unrecognized disease or defect? We search it by means of some rapidly applied tests, examinations or procedures. And in whom do we conduct this search? We do it in apparently healthy individuals. A screening test is not intended to be a diagnostic test. It is only an initial examination. So those who are found positive on a screening test are referred for further examination and workup in order to diagnose them properly. So there are certain important distinguishing features between a screening test and a diagnostic test. So screening test, as we have defined it, is conducted in an apparently healthy individual or group of individuals, whereas a diagnostic test is usually done in those people in whom there are indications for doing that diagnostic test. Screening test is applied to groups usually, but not necessarily, whereas diagnostic test is most often applied to individuals. Now the result of a screening test is either positive or negative. That is, we screen the person as positive for certain condition or as negative for certain condition. Whereas with a diagnostic test, we may not get a yes or no answer. We may go for further evaluation of the patient before giving a final diagnosis. So screening test is based on an arbitrary cutoff point, which makes it less accurate, whereas diagnostic tests usually are more accurate. But the advantage of screening tests is that they are less expensive and diagnostic tests are more expensive. Screening tests do not usually form basis of treatment. So we don't start treating the patient right away if the patient is screened positive. Whereas diagnostic test, once you establish the diagnosis or confirm the diagnosis, usually they form the basis of treatment. For screening, the initiative usually comes from the investigator or government agencies' health programs. Whereas diagnostic test, usually the initiative comes from patient or his physician based on the complaints that the patient has. Now you must remember that this criteria is not hard and fast, and some tests can be used as screening tests and diagnostic tests as well, depending on the situation. Screening is not useful in diseases which are apparent at their onset itself. It is useful in conditions where the onset occurs early but patient remains asymptomatic for long duration of time. So in such cases we can catch these diseases earlier with help of screening tests. Which brings us to lead time. Lead time is basically the lead or the advantage that is given to an investigator by the screening test or the screening program. So if we are able to detect the disease at an earlier time, it is this time, at the first possible time of detection itself, we can alter the course of the disease and improve the outcome of patients or prevent the transmission of disease in the community. There are four main uses of screening. First one is for individual case detection. It is also known as prescriptive screening. Just like we prescribe drugs, we can prescribe screening tests to an individual for their own benefit. So it gives you the presumptive identification of unrecognized disease in individual. For example, cervical cancer screening or breast cancer screening in women, diabetes mellitus screening in elderly, iron deficiency anemia, or pulmonary tuberculosis screening. The second use is for control of disease in the population, also known as prospective screening. Here the people are examined for benefit of others. For example, screening for tuberculosis. So if a person is infected with tuberculosis, he or she will spread tuberculosis to the close contacts. In order to prevent that, if we are able to catch the tuberculosis early on, we can start the treatment and that can prevent the spread of tuberculosis in the community. The third use is for research purposes. So the natural history of many diseases is not known. A screening program can help us acquire information of public health relevance of the disease that is being screened. The fourth use is educational opportunities. While we are conducting the screening program, we will also spread health awareness in the population and educate the healthcare professionals who are conducting this program. A screening test must satisfy certain criteria in order to be successfully implemented. The first thing is that it should be acceptable. A high rate of cooperation is necessary to carry out screening tests. If the people on whom these tests are done are uncomfortable or embarrassed due to these tests, or these tests are painful, then they are not likely to be acceptable. The second important attribute is that they should be repeatable. So ideally the test should give the same results no matter how many times you do the test on the same individual. Now there are certain factors which reduce the repeatability or introduce error in the tests. These factors are observer variations. They may be intra-observer or inter-observer variations. Then biological or subject variations, and errors related to technical methods. For example, defective instrument, defective calibration, and faulty reagents. The third important criteria for a good screening test is validity or accuracy. It refers to what extent the test accurately measure what it's supposed to measure. There are two important components of validity. The first is sensitivity and specificity. Both these measures are given in terms of percentage values. Now we will see evaluation of screening test and deal with sensitivity and specificity in details. Before we begin with evaluation of screening tests, we should know how to make a 2x2 table. So 2x2 table has 2 rows and 2 columns. These are totals. The 2 rows show test results. They can be either positive test or negative test, and the columns show whether or not the disease is present, so present or absent. We can get 4 results out of it. The first one, or which is labeled as A, is true positive. Test is positive and disease is also present. Second one is false positive, where test is positive but the disease is actually not present. Third outcome can be a true negative outcome, where the test is also negative and disease is also not present. And fourth outcome can be a false negative test, where the disease might be actually present but the test is negative. Now we'll see how to make this 2x2 table with help of an example. Now this is the example. In a town of 1500 people who were screened for a disease, of whom 900 were found to be positive on screening. So 1500 लोग थे जिनको स्क्रीन किया है, उसमें से 900 जो है वो पॉजिटिव आए हैं. On further evaluation, we found that 600 of those who were positive actually had the disease, and 150 of those who had tested negative also had the disease. Now we have to prepare a 2x2 table. So the first thing we will do is prepare the skeleton of the table. This is the skeleton of the table, where we have 2 columns, disease present, disease absent, and 2 rows, test result positive and test result negative, and columns and rows for total. The second thing we will do here is add the given values. So in given values, what all given values do we have? The total number of people who were screened. So total number of people who were screened will come here, which is the grand total. 1500 people were screened, of whom 900 were found to be positive. So the total number of people who were found to be positive is 900. So that will be here. 600 of those who tested positive, actually the disease was present. So this will be the number of true positives. Whereas 150 of those who tested negative also had the disease. So this will be the number of people who tested negative but also had the disease. Now what we will do is we will fill the blank spaces by deduction. So just add this, that will be 750. So disease was present in 750 people out of 1500 people. So that means it was absent in again 750 people. So 750 plus 750 is 1500. Now how many people tested negative in all? So that will be the 1500 minus 900, you will get 600. 600 people tested negative. And 900 minus 600, you will get 300. 300 people who tested positive but the disease was absent in them. And remaining value is 450 when we subtract 150 from 600. So in this way you can make a 2 by 2 table based on the data that is provided to you. This can be asked as a epidemiological exercise. This is the 2 by 2 table you will get at the end. Sensitivity. Sensitivity is the ability of the test to identify all those who have the disease, that is to identify true positives. This was introduced by Yerushalme in 1940 as a statistical index of diagnostic accuracy. What it actually means is that if a test has a sensitivity of 90%, then 90% of the people with disease will show a positive test. Now how do we calculate the sensitivity? Sensitivity is calculated by the formula true positive upon true positive plus false negative, that is A upon A plus C. So on the 2 by 2 table we can create make such an arrow and denote the sensitivity. The formula is A upon A plus C. Multiplier 100 is used to denote the value in percentage. Let us understand how to calculate sensitivity with help of this example. So this 2 by 2 table is given to you and you have been asked to calculate the sensitivity of the test. Now we know the formula for sensitivity is A upon A plus C into 100. So what is A upon A plus C? A is 600 and A plus C is 750. So sensitivity will be 600 upon 750 into 100, which is 80%. Specificity is the ability of the test to correctly identify those who do not have the disease. That is to correctly identify true negatives. So if the specificity of a test is 90%, then we can say that 90% of those who don't have the disease will test negative, while 10% will be wrongly classified as diseased even though they don't have the disease. Now looking at the 2 by 2 table, how do we see specificity? Specificity is given by the formula true negative upon true negative plus false positive, or D upon B plus D, that is this arrow. So if you make this arrow, you will remember the formula for specificity. Let's calculate the specificity in the same example. We have seen that specificity is the ability of a test to correctly identify true negatives, and given by the formula D upon B plus D, that is in this example 450 divided by 750, look at the arrow, into 100, which gives us the answer 60%. In addition to sensitivity and specificity, the performance of a screening test is measured by its predictive values. Now these predictive values reflect the diagnostic power of the test. Now predictive accuracy depends on three things: sensitivity of the test, specificity of the test, and prevalence of the disease in that particular community. The first is positive predictive value. Now positive predictive value indicates the probability that a person who has tested positive actually has the disease. Just like sensitivity and specificity, where we considered the columns of the 2 by 2 table, for predictive values we will use the rows while computing the formula. The formula is A upon A plus B into 100. You can remember it by drawing the arrow horizontally from the positive row, that is A upon A plus B into 100. Similarly, the negative predictive value indicates the probability that the person who has tested negative doesn't actually have the disease. Just like specificity, you will find that instead of rows, if we draw an arrow from the true negative column to the row total of negative values, we will get the formula, which is D upon C plus D into 100. So this is the formula for negative predictive value, D upon C plus D into 100. Let us see the negative predictive values and positive predictive values with help of the same example. Now for positive predictive value, we know the formula is A upon A plus B, that is shown by this arrow. So substituting the values, the answer will be 600 upon 900 into 100, which is 66.6%. For negative predictive value, the formula is D upon C plus D. So substituting the values, it will be 450 divided by 600 into 100, this arrow, and the answer will be 75%. So a simple trick to remember the formulas for sensitivity, specificity, positive predictive value and negative predictive value is to draw arrows on the 2 by 2 table. So to get the formula of sensitivity, you draw a downward arrow from the first column of the 2 by 2 table like this. So the formula is A upon A plus C into 100. For specificity, you draw the smaller arrow on the second column, that is D upon B plus D into 100. Similarly, for predictive values, you can draw arrows along the rows. For positive predictive value, a long arrow on the first row, that is A upon A plus B, and for the negative predictive value, a short arrow on the second row, that is D upon C plus D into 100. Now that you know how to calculate the specificity, sensitivity, positive predictive value and negative predictive value for a screening test, you can solve this example. Auxiliary health workers screened a group of 149 school children for clinical signs of streptococcal pharyngitis. This was followed by throat culture of all students for group A beta hemolytic streptococcus as confirmatory test. Following table is a 2 by 2 table which shows the comparison. Now you have to calculate the sensitivity, specificity, positive predictive value and negative predictive value of these examples. So these are the answers. You can solve and check. You must always write down the formula, substitute the values in the formula and then write the answer. Don't forget to put the percentage sign in order to get full marks. Now that we have completed today's part, I am giving you 3 questions for homework. The same questions will be given to you in a Word file on your WhatsApp group as well. Also, I will be sharing some more solved examples with you through WhatsApp. We will be having one more lecture on screening where we will be covering false negative and false positive rates, yield, how to calculate the sensitivity, specificity, predictive value by combining the tests. Then what are the problems that you face while assigning cutoff values and how do we evaluate screening program and what are the diseases that are amenable to screening. So this all will be covered in the next lecture. In the meantime, you are expected to solve these questions on your own and you can share the answers with me on WhatsApp. Thank you.